Yes, ma'am.
Do you have a Word or like a Google Doc study guide made for exam two?
Probably do. Didn't you get it yet?
I might have, but I'm not sure.
I'll send it. We're gonna do it after the break. Figure why stress you, but we'll probably do it the Wednesday after the break. That's the plan.
Is it gonna be on Blackboard or?
Right where you're sitting. Directly here. Good, good. Everybody good? What? Oh, you're just a beacon of sunshine. Here you are. Hi. You are. I have the last two students' sons. One. Once those are done, I'll try to get everything processed and out sometime tomorrow. And then Friday you can look at them and all that good stuff. Reasonably. Right? All good? I know. Not easy. We had to take them at different times and all that good stuff. Friday accommodation. So let us begin. Oh, we were recording already. That's the plan. All right. We're back to blood. I love blood. My favorite. This is one of my two favorite units that are there. Uh, I think the way I haven't figured it out yet. I think this is good. I sent you a note about a lab midterm. I think this is more lab related. I wanted to give you some background on the blood. Oh, we have to do endocrine. I forgot again. Why? Your job to remind me.
I thought we were done.
No, we got to do about diabetes. Oh my goodness gracious, Sydney, you really need to help me. I rely on you to keep me centered.
I'll do better next time.
Yeah, the blood is going to be part of that lab midterm. That's going to be take home. Okay, I know that will ease your apprehension. Oh, I apologize. Not a lot. It's been. I'm still good now, but boy, when I have to do lab after, that wipes me out. Do not use that O word ever. I am not. I swear to you, my wife it's a conspiracy. She's trying to drag me and keep busy, so I wouldn't even think about how tired I am sometimes. So I am constantly being forced to do activity, which I do not wish to do. All right, yeah. Thank God. It's more of me telling you about it than stuff they have here. Okay, so we got to the pancreas, and these are the islet cells. Remember, we have glucagon, okay, all that. I'll buy all this glycogenolysis, gluconeogenesis, insulin. Yeah, it has to be broken down, transport, etc. We we don't have to worry about it in these areas. They have other means of collecting the liver, basically, as part of gluconeogenesis. So if it needs glucose, you can find it. The kidney can retain it, is what we talk about when we get to urinary function. And the brain only thrives on glucose, so it uses whatever it is. Does it play a role in all of these things? Yes, it uses that tyrosine kinase system that's there, triggering the cells to increase glucose. And I'm sure we've mentioned this before. There's always more. It facilitated diffusion because there's always more glucose outside than inside the cell. Because as soon as the cell brings glucose in, G6P it immediately phosphorylates it, and G6P is not glucose. So inherently, any cell brings in glucose, and immediately the gradient is maintained, no matter how much glucose goes in. And yeah, other things you can do, all those types of things that we discussed. So primary stimulus, increased levels typically associated with eating. Typically, again, amino acids and fatty associated with eating. Acetylcholine certainly would be a stimulant that's involved with it, but typically that's associated again with the levels of eating and perhaps even expansion of stretch receptors in the esophagus and the stomach might play a role. Other hormones will influence either positively or negatively. Again, growth hormone seems to oppose it. To a certain extent, epinephrine may oppose it. Thyroxine is important for both, but it may even oppose it. Okay, and we'll take a look at all those as we begin to discuss it. So without getting too much into the fine points of what acts against it, what's pro or anti-insulin, I really wanted to spend some time with diabetes. The misconception of diabetes is that it's high blood sugar and only high blood sugar, but it's really, I think a better way to look at it is it's inappropriate utilization of sugar, typically characterized by high blood sugar levels. Okay, so it really has to do with how it's being utilized as well. Even though we see higher, some people run higher blood sugars. A lot of times we erroneously call them diabetics. Maybe they're better characterized as pre-diabetics because it's all about utilization to it. Do you want to write it? Read it right fast. I got it. Turn it on. So I said I'm going to turn on the light. WT. I just remember that. Your responsibility is to equate with pop culture references, which I know. So take some time. Now you have to come to you. So whatever you folks are talking about now. Terminology that I would not expect. It took me a long time to understand my kids. And my kids are, roughly all 40. I don't even understand that. And my daughter, even though she tries to successful. We're waiting for the video. I do not know if I can show it in class because I think it may have it. Some of you may not be of age. Nevertheless, this really, to study diabetes, and I take the time to do this because I think it's so important. We look at blood sugar. We look at time. So basically what I'm constructing for you is something that is the way we used to diet, used to utilize. We still do utilize to a certain extent to diagnose diabetes and pre-diabetes. There's other diabetes related sugar diabetes. So we want to look for inappropriate sugar. So this was called the glucose tolerance test. And sometimes it's clear after 2 hours, sometimes it takes as much as 7 hours. It starts at time 0, and this is blood sugar levels. This is with fasting. So you typically do an overnight fast. This is time 0, and you measure it in half-hour increments. 1.5, 2. Yeah, and sometimes you can go longer, 2.5 to 3, depending on until you really see the utilization over time. Effectively, what happens? You measure the typical norms that you would have for blood sugar. At least the ones I grew up on were about 65 to 110. That was a typical fasting blood sugar. It's not. We still use that to try to diagnose. I mean, if someone has a fasting blood sugar over 100, it's most likely. But I mean, there's a gray zone when you get into that 110 to maybe 130, because there could be a variety of other factors depending on what's going on in the body. So you have to ascertain more information. At that point, you give them a test load of sugar. So in that first half an hour, typically in about 15 minutes, you give them, they need to consume roughly 100 grams of carbohydrate, CHA. 100 grams of carbs, and normally they give, the way they usually give you the drink that you had to have was called cola. So either be a cola-based drink or an orange-based drink, whatever they had on hand. And over that Once they did that first stick for blood stick, then it was like, okay, you got 15 minutes, drink it. It's sickeningly sweet. It's dark. It's like you want to keep it up. At that point, then they start measuring at half-hour intervals. That's your test load. Well, that's a lot of carbohydrate. So what you expect to see, let's say you were at 100, what they would expect to see normally is it will go up at that first half an hour. Maybe we'll go up to 150, 175, 200 pickle. And then what would happen basically, if it was done properly, it would take about to 2 hours to settle back to the rest of it. This is kind of what the curve would look like. Might even overshoot. So that would be a typical glucose utilization. Even if you had somebody who had 120 and it came back and came rested and came back, you'd say, this is pretty normal. Maybe you classify them as pre-diabetic. Pre-diabetics with a history of diabetes, women who bore oversized babies, now it would be more than 9 pounds. What I learned about it was more than 10 pounds because we were very lax. OBGYN science thought that it was okay to eat and gain 50 pounds. Now that's certainly not the case. So its number went from 10 pounds to 9 pounds. So again, diabetic relative. Okay, some people even during pregnancy are more likely to demonstrate what they call definitely it's a chemical diabetes or stress diabetes. Times of stress and pregnancy is one of them. They actually demonstrate more typical diabetes. Those are all part of it. And the other things include if you had one of these, and remember I tell you, living systems don't make sharp turns. It's sort of like a big, you get something that really, you have something where it went very, very low. Because once you go below 50, you're hypoglycemic. And this is something famously referred to as reactive hypoglycemia. That's a real tell, a real giveaway. Someone's pre-diabetic. So there's lots of things that can impact what's happening. A lot of times you can't tell, so we look for irregularities in the sugar utilization curve. Now it's different today. We look at fasting blood sugars, and we can take those and we can do blood sugars at intervals because now we have glucometers that are incredibly important. It's easier to put your finger, something we can do in the lab if you want to. And I have one of those little glucometer things, just a strip, it's a color ribbon. Basically, there's a reagent in there, the color, and the strip will read the color, and whatever the little chip in there will convert that. Will have whatever the computer component to translate that to. So we use like that, and then we have this other wonderful thing that we can do with a blood test. You know what it is? Hemoglobin A1C, known as glycosylated hemoglobin. Now, not only does that tell us, I think the norm is for glycosylated hemoglobin, anything under, I think, 5.9 or less, 6 or less. And so if somebody has the glycosylated hemoglobin 7.5, you don't have to worry about they're a diabetic. Yes, sir.
Can they tell that the diabetics are lying about their diet with that as well?
Oh, sure. It's a very good indicator because if you're consuming, if you're not taking care of your diabetes, if you know anything about diabetics, I can't tell you how many times I used to do house calls all the time. There's one lady who already lost a leg. I'm there trimming her nails in bed. So she's in bed. She can hardly get out. I don't even think she had a prosthesis she could use. It's really nice. And as I'm walking over to take care of her, her nightstand is open. And in there, I've never seen so many candy bars. It looked like my nightstand. I mean, I appreciated that. She had Twix bars. I mean, chicken. I'd walk a mile for a Kit Kat.
And then it's okay because you want.
I mean, yeah, for me it would have been okay, but the one leg thing would have influenced her adversely. And I'm like, you know it. I said, I'm not going to tell whoever referred Dr. So-and-so, but you're not doing it. This poor lady wasn't going to have that long. I'm not going to appreciate it. But that's what the A1C tells you. The A1C And it also tells you how well your therapy is going. If you're doing it successfully, and diabetes involves everybody, it's not just the patient, it's their family. She was by herself, unfortunately. In a little house, in northwestern PA, somewhere on a hill of the poorer district of Oil City. It ain't pleasant, but a really nice lady. And understand that modern theory with taking care of folks who are diabetics is multifactorial. The whole family, the children, the spouse, the people, you bring it in, it's almost like an intervention you would have for someone who's an addict. The whole rule is aggressive sugar control early, very aggressive. You want to keep them under a certain level. You want to keep them under. Some diabetics are so labile, you typically want to keep them close to whatever a typical normal would be. Let's say under 125. Some, if you get them under 150, it's a blessing. But it requires everybody. You want to make sure that they're active. You're looking at their diet. You're with them a lot. You got to be at the workplace. Make sure they're not like me sneaking candy. Not blaming yourself, blaming that funny looking guy named Badger. I mean, candy. I'm being facetious. He's trying to blame his wife. Well, she uses the candy for chemistry, and I have to bring her to class. Yeah. She had like 6 bags of unopened candy she didn't use. But I'm very happy. I like this. I'm a Starlight Mint. I'm a Starlight Mints Anonymous. We have meetings at certain times with the stars. Right? Starlight, you have to explain it. But that's the A1C. So you're able to monitor their progress. That multifactorial approach, that approach that involves not just doctors, rehab, exercise, training programs, nutritional programs, it was developed by the Joslin. It's called the Joslin method. Joslin is associated with the Davis Scarborough Medical School, and they basically were able to develop their program so it could be utilized in other areas. So a lot of diabetologists and endocrinologists were Joslin trained and used that method. They had a fellow who was at West Penn for a very long time, brilliant endocrinologist, diabetologist, and what else was he? He had 3 certifications: endocrinology, diabetology, and also nephrology. And I think Jerry probably retired by now, but he over here at Sleeping House. I have to look. See, because our sons went to school together and actually went to college together. They weren't necessarily friendly, but they knew each other fairly well. I've lost track of him, and my son's lost track of his son, I'm sure. But nevertheless, it's a really useful method. I am fortunate. My grandfather's diabetic on my mom's side. I am not. My uncle, my mom's brother, became diabetic later in life in his 60s. He lived to be 80, and it wasn't. And really, that was probably not necessarily that impactful in his demise, so to speak. So it's very interesting how that is. Not so much my dad's side. So, I mean, those are a lot of factors. Now, here's how it breaks down and why it's so important for me to go on this spiel with you, as well as just me talking. And that is the 2 types. And what we have found today is it's different. The rules don't apply like they used to. When we learned about it, there were 2 types: juvenile onset and maturity onset. Juvenile onset, anybody under the age of 40, and by definition, we thought they were insulin dependent and you had to give them insulin. And usually it showed up when they were in their teens. And typically they were slender. We painted with such a broad brush. We didn't have the availability of these tests. They had high blood sugars and abnormal glucose tolerance tests. We didn't have the luxury of A1C or other factors that we could explore. Maturity onset, people over 40. And typically they were only if they were very severe, they require insulin. And they used a lot of oral agents, which were typically very ineffective. for that and had a variety of side effects, not the least of which were damaging blood vessels that led to increased risk of arteriosclerotic heart disease and other diseases, cardiovascular incidents, in their infancy. Okay, basically those kind of meds were very unsuccessful, and most time they came out, wonder drug got pulled right away, which led us to being able to change the criteria. They call them then type 1 and type 2, insulin and non-insulin dependent, but typically the broad brush apply. Not so. Type 1, by definition now, there's some problem with the insulin. You're not secreting enough, or there's some inherent problem with the formation of the insulin on a DNA, RNA, protein synthesis barrier. Would be a better way to describe it. Most commonly, hyposecretion, I would agree. Is it more frequently younger than older? Yes. Is it confined there? No. So we see mature adults over the age of 40 with this, and then having the insulin non-functional, and typically the association is the receptors. There seems to be an inherent fault with the receptors, either over time that develops. A lot of the theory was that constant exposure to excessive amounts of glucose altered the glucose receptors with regard to their ability to respond to the insulin. Maybe that was the source of the so-called hypoactivity, but there was a combination of lack of activity and lack of responsive receptors, if you wanted to be thorough. And the biggest single problem we have today are sedentary young people starting in grade school who are, like many of us, are slaves to our computers, working remotely. Also added to it, COVID with lockdowns, people worked out of their home. There's very little activity that they did. And the amount of gaming that's done is excessive. So you all know people like this. It's a hypoactivity. We call it metabolic syndrome or syndrome X, and it is extraordinarily dangerous. And so a lot of it is lifestyle, a lot of it is understanding. I mean, even if you were so afraid of COVID that you were walking around with a mask in the outside and nobody else is around, and or you're people who are driving their car with a mask still on. Okay, if you've got covophobia, whatever you want to call it, that's fine. And this is Blue's spin. This is my spin. I mean, if that's your that's fine. Do whatever you feel comfortable with. But the reality is, go out and take a long walk. Even when we were locked down, my wife and I were walking all over the neighborhood. Yeah, we're on the opposite side of the street. The dog's looking at us. Enough! Tired of walking. Every time it's like, oh, I'm tired. I'm not. We try to drag him. We just put him back in the crate. And that was the dog before the dog we have now is much more active. Okay, and understand that's it's activity. It's changing their diet. It's becoming more physically active and dietarily active. Those are the secrets. So they call it metabolic syndrome or syndrome X. It is a real scary. I mean, you and I all know. Okay, and I'm not looking at a classroom who would necessarily be the definition of it, but you've all seen it. We have a tremendous problem with obesity in this country. Hello, pot. This is kettle. Okay, I'm no skinny person. I grew up being weighing almost 280 pounds. When I was 20 years old, I was over 260 pounds. My doctor got really scared the poo-poo out of me. So I was going to say shit. He did. He goes, my blood pressure was like 160 over 100. I'm 20 years old in college at Seton Hall University. He goes, when can I book in for your stroke? And I love the guy. Okay, wasn't the world's best doctor, but he was a good friend. You know, and basically at that point, all of a sudden I went, I'm not so much a low, basically 1,500 calorie a day diet, and boom, 3 months, 50 pounds. See you later. And other than that, I've gained and lost people. I will tell you that. I've been down when I was sick, very sick a couple of times into 160s. If you had, you might have been for how heavy I was because I started losing when I was teaching your class in the fall of whatever 23. I weighed about 230. I'm like 50. I'm easily 40 to 50 pounds less. But I'm a yo-yo because I don't have a lot of self-control. The reality is diabetics are like that. So there's a variety of reasons, like I was explaining to you, particularly with cardiovascular. In the back of my mind, my dad succumbing early to that. He was a much more healthy, apparently, and robust man than I. Okay? Shocked people who we've said die. Believe me, we were like that too. Okay. Nevertheless, we call it the three polys. Think what happens for whatever reason you have too much sugar in your system. Number one, you have too much sugar in your system. Your kidneys don't know that. And this is why the aggressive control is so important. There's a thing called transport maximums. We're talking about that a little. We stopped in MCAT today talking about it. The T max is approximately 180, let's say, or 185 for glucose in your kidneys. And that's why aggressive control, a diabetic, once a diabetic gets to this area or above it, then we say we find sugar in their urine. That's a pretty high number. But what happens over time, the longer that those transporters are occupied transporting sugar, they get damaged. They function less efficiently. So when you're at or around transport max or T max for glucose, it starts to lower. And I mean, a couple of years later, now you're at 150, and all of a sudden you're spilling sugar into the urine. We call it glycosuria. And that's certainly one of the major signs. If you did not know it before the advent of insulin pumps and different systems and the availability of glucometers, having to go to the hospital and get your glucose done in the morning, effectively, you just didn't have that technology. When I was saying it, we did urine testing. So diabetics would get up in the urine and they dipstick it. Something called Clinitest. It was like a test strip. If you have a pool or a hot tub, you dipstick it. Same thing. And it would turn certain colors. And we had a sliding scale. So, and whenever they would urinate, they would do that, and they do their insulin in the morning. And if they were still spilling, like +1, you have 5 units of regular insulin, and +2, maybe 8 units, etc. So we call it a sliding scale. And a lot of times when you have one who's out of control, you start with that. You say, take them off all their other medicines. Now we're just going to start with that. We're going to use a basic dose of insulin, which is the sliding scale. Different management today. So polyuria, when the glucose is spilling, it's like any other solute. It pulls water along with it. Talk about Mary had a little lamb on steroids. You know, I was going to say. So it pulls water with it. So you urinate, polyuria, osmotic diarrhea. What happens when you're losing water? You're thirsty, polydipsia. Okay? And because your cells are starving because they can't get the glucose in for whatever reason, whether the insulin, whether the receptors, now you're hungry. So your cells, your body doesn't know that. It's just, I don't have enough energy. I'm going to start eating. And frequently, the cravings are much more about carbohydrates than anything else. And so that's polyphagia. And because the cells are starving for energy, guess what? Fatigue. The one they don't tell you. Typically, when they're like that, there's not a lot of energy that they have. So it's the three polys and fatigue. Tiredness, they tire easily, yes. A lot, constantly. It, it's 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 such a hard management. You're hungry for carbohydrates and you're hungry in general. I can't have carbs and just eat something else. And it's not like, well, I'll just eat, complex carbs and blah blah blah. I can tell you they're the worst cheaters in the world. My best friend's dad, like it was yesterday. In the early days of pro football, he was a lineman in the 30s. From return. When we met, I mean, his arthritis was so bad he was hunched over, terrible diabetic. I remember when we were 18 years, we were just probably starting college. We were going to visit him in the hospital. They had already cut off the leg. He was losing toes on the others. I mean, eventually he succumbed to stroke, things like that. And they told my friend when he had moved to Florida, where he resided for 50 years, that he was a pre-diabetic because he had seen what his dad had gone through. He never. I said, we go out, play golf, we go out, have some, something good to eat, a couple of beers. He go, so don't you want? He goes, I never cheat because he had been so impacted by seeing what his dad had suffered. He just had so much willpower. So it's rare that you find that. So I remember like it was yesterday. Never cheat. And here I am. It's all right. Oh, you don't want the rest of that sandwich? I'll eat it.
That's what I
You're skinny. It doesn't count. But so a lot of that is inherently, it's very, there's such difficult management problems. And now we get to what the big problem is. Because of that, diabetes, for years, we thought the side product of having to use, and really what happens there, if you can't use carbs, what do you use? First, carbs, fats, proteins. Use fats. And it doesn't matter, okay, whether you eat healthy fats and whatever, etc., that when your body metabolizes fats, you're going to form keto acids and ketone bodies, period. And that's going to put a strain on your kidneys, even on top of transport maximums. Okay? Those fatty acids and ketones are basically going to manifest themselves by eventually damaging blood vessels. We know it's associated with microvascular disease, and it's just a terrible combination. And we see characteristic areas. It affects, we used to think it was typically capillaries and basement membrane thickness. I think it's more complex than that. I don't know what the current view of diabetic physiology at that level is, but they thought it was basement membrane thickening was the giveaway. There's a lot of different things and nuances that they understand better now. But effectively, it's why we're so careful. Remember, we talked about looking in the eyes and looking at the arterioles there. Those arterioles, leading cause of blindness, diabetes. Leading cause kidney failure, diabetes. Okay, so what happens in those arterioles are happening in it's an arterial. So it's a one-way look. We can see in the arterioles in your kidney, and we know, particularly in type 1, we know there's an autoimmune component. Because what we see that makes it even worse for the kidneys, we see antigen-antibody complexes. Have you discussed antigen-antibody complexes precipitating in the kidney in immunology as yet? It's one of the years ago we didn't know what caused them. It's called Kimmel-Style-Wilson disease, and we knew it was associated with diabetes, hypertension, and edema. So they had diabetes, they had high blood pressure because the kidneys were being impacted, and they had edema because the kidneys were being impacted. And we saw these proteinaceous deposits in the kidney post-mortem. And so we knew that was a bad diabetic. Little did we know that when the age of molecular, I was learning about this before molecular biology was a science or in its infancy. Then they started to analyze those deposits, and they found they were antigen antibody complexes. That's why we think the vast majority of type 1 is an autoimmune, it's an immunological phenomenon. Maybe there's an underlying virus we haven't discovered. Maybe there's something that is going on. So it's the characterization is an autoimmune disease. Where type 2, I mean, yes, there are some people who are genetically impacted by that, faulty receptors, aspects of the insulin that isn't utilized properly. I'll buy that. By and large, it's very lifestyle oriented. I mean, I know this is broad brush. We could do, and you have to get somebody, you have to get a diabetologist to teach you. We could spend a course that would last a year, 2 semesters, talking about nothing about diabetology. I can't tell you how many conferences I went to where it had one topic. Remember, I was all about feet. Nothing manifests itself. Anybody who does feet for a living, 65, 70% of the patients are diabetics, period. I mean, we go to these ones, the diabetic foot. What genius authors, just the whole weekend about it. Not exciting, not about operating, not about new surgical techniques and all that fun stuff. No. Very nuts and bolts stuff because we're dealing with patients who have long-term chronic problems. Really problematic. So we get lipidemia, causing high levels of fatty acids. The boss wants to know where we go. They're terrible. Ketones and ketone bodies, which we talked about. And so what happens, they are effectively acid containing, and we get ketoacidosis in the absence of control. So if we don't have a means of utilizing those sugars, and if you're going to ask me about things like Ozempic and these new, I do not know anything enough about them to tell you. Right now, it's a little scary. Yes, sir.
I think from what I've heard is that they just work by blocking GLP-1 receptors.
Right. I mean, the question is, we short term they're looking. I mean, other we're talking about people who are doing it because they're just for weight loss. And they're not diabetics. Question is, 5 years, 10 years, 15, 20 years from now, what are the long term side effects? So a lot of new things come out, and we think they're best things since sliced bread. And all of a sudden, there you go. I mean, I can tell you how many arthritis medicines they pulled. You know, there's a wonder drug. It doesn't cause GI distress and it'll cure your arthritis. And it's a nice thing. Oh my God, we did a long-term study and found it accelerated cardiovascular disease. Check, please. Yeah. It's marketing that does it. As Mel Brooks would say, merchandise.
Something that someone was having bone density issues.
Yeah.
Because they didn't need it.
Pardon me?
They didn't need it per se. They were pre-diabetic. They just used it to lose weight.
Just lose weight. And so these are the kinds of things, if you don't have the appropriate, we're going to see that. Remember, just plain yogurt, merchandise. Spaceballs or lunchbox. I'll show you the clip. You're all looking at me like you don't know what I'm talking about. What? Of course. Poster, office. So ketonuria, ketone bodies. And again, that's one of the tells. When we see someone passing ketones who's a diabetic, that's a slam dunk out of control. If you're on a ketosis diet, you want that. You want to measure your ketone levels, but you only do that if you have competent kidneys and you're hydrating. You got to flush that stuff out. We were very successful on keto, my wife and I. So, and this is what happens: ketoacidosis, acidotic. Respiratorily, you compensate. You get that breathing problems associated with it. You're trying to blow off carbon dioxide to reduce the acidity levels, and sooner or later, you get that, and you get that. And the trick about diabetes is too much and too little. They're both fatal. One kills you slowly. High sugar. Diabetic comes in. They have a bracelet, they have a necklace, they have a card in their wallet. Somebody's with them. Oh, it's diabetic. He just collapsed. What do we give them? Sugar. Okay. If their blood sugar is 700, who cares if it goes to 1,000? We can get that down. High blood sugar kills you slowly. Low blood sugar kills you now. Because when you're below 50, all of a sudden your brain, you start to feel shaky. Classic example, a person took their insulin, okay, and I'll take my insulin, I'll grab something as soon as I get to work. It's a short drive. Whoa. And all of a sudden, boom, you get a traffic or a problem like that. They didn't have something with them. They're lucky. My favorite patient of all time, brittle diabetic, died, probably didn't make it, sure he didn't make it age 60. He died at about 56. Loved him to death. Wonderful person. Wonderful faith. Good and admirable person. And it's like, what happened? You missed your appointment. He goes, I ended up in the hospital. He lived in Titusville, PA. And what happened? He worked at the senior citizens facility. He took his insulin, drove 15 minutes to work up Route 8. And the next thing you know, he goes, I remember, I got out of my car. It's the last thing I remember in the parking lot. And all of a sudden, just like in the movies, in the hospital, they give them D50, dextrose 50%, a high bolus of sugar. And he wakes up, where am I? What's wrong? They found you collapsed in your parking lot at work, right by Titusville, if I have any idea where that is. Amazing. And he told me that story, and it's like, he's lucky he didn't run over somebody. He's lucky he didn't run into a tree while he was driving. He hurt himself, kill himself, or God forbid, hurt somebody else. It's the only thing I can think of. So these are some of the problems that are attended with it. So that you have to be very cautious about that. They have to get up when they get up late. There's all these things. It's really what in medicine we call these management problems. They are difficult to manage. They're stubborn. They don't change. And any of you going into a medical field, if you're going to encounter diabetics, be ready. You really have to. You can be nice, but you have to be very firm. And some of them you have to be more that are there. All those things. And so that low blood sugar, now that can basically send you effectively into we call shock, the treatment of sugar, versus high blood sugar when you get acidosis. I mean, that you're immediately life-threatening, but it takes a while to get there. That's more of what we call a diabetic coma. I don't know if the terms still apply the way they used to. So, insulin production is excessive, hypoglycemia is what I'm talking about. I mean, you all of a sudden you feel very disoriented and boom. If you don't get sugar, that's when most diabetics, when you sense that, they have a little prodrome or a little feeling, they'll have an emergency candy bar. They'll have a little glucose tab in their wallet or in their purse or in their vehicle or in their desk. And they just have that there just in case. They slip it under their tongue, they slip it in their mouth, right on, and they're there. And that's what why the hospitals do it that way. So the treatment, sugar injection. And you can go over all of these things. I don't feel like reading it, and I don't feel like going through that in the interest of time. And then really, that's to me the sum and substance of what I really wanted to share with you is the complexity of the diagnosis. Really, it's fascinating. If you're going to go into a medical field or you're going to treat adults, you are the disease you can't know enough about. Because that's good. Write down all the diagnoses that you see in adults. We have arthritis, we have high blood pressure, we have heart disease, we have digestive problems, and a lot of them have diabetes. And the thing you always want to be familiar with if you're in the medical field, the things that are common you want to know about right away. The things that aren't, you look up like everybody else does. If somebody comes in with whatever, trying to think, Gaucher's disease, which is a genetic disease that involves similar to Tay-Sachs but not the same. It involves bleeding. I mean, you have to do an elaborate workup and do a family history to find it. You look it up. It could be this. I didn't answer the question. But diabetes, I got to know right away what's going on with that. And then you start looking at the nuances and you see something unusual. It's just the way it works. Just to complete, very little time left, and I wanted to finish it. Okay, estrogen and progesterones, basically we know are produced by the ovaries, and what they're pretty straightforward what they do. Reproductive, secondary sexual, progesterone, significant. We get, and some of we already discussed it with the MCAT students, effects on the uterine mucosa, getting it ready for implantation. This is the drug, not the drug, this is the hormone that is most active during post-ovulation, and yeah, it plays a role as well as breast development. Testosterone, male reproductive, secondary sexual, sex drive, etc., etc., etc. And down the road, when we talk about repro, we'll look at HCG. That's made, just the first one that's made by the placenta, and subsequently, estrogens and progesterones are made. The HCG is the trigger that tells the corpus luteum what's left of the ovulated, not of the egg, but of the enclosure in the ovary called the follicle, that takes over, and the placenta, once it matures, basically takes over it. The HCG is telling that corpus luteum after 10 days, keep working, re-implanting. And that's the source of the early pregnancy test. It's so reliable. Vast amounts of it. First warning, you're an easy test. Remember the movie Juno and all that stuff. Can't miss it. Leptin, very important for fat. So adipose cells release it. Stimulates increased energy expenditure, so levels of that play a pivotal role. We look at reproductive, and there's some other ones that are there that I don't know enough about to really discuss it with you. We get to a lot of these when we're talking about gastrointestinal. We'll talk about gastrin, we'll talk about secretin, a little bit about ghrelin. I mean, that's just, yeah, as the stomach is stimulated, it will basically, there are certain things that the stomach sends that produce appetite. That's where that ghrelin comes from. We'll talk then in digestive phys about secretin and cholecystokinin. Okay. Again, these are a little less basic than you would think and less commonly part of this course. If you go into it, that's medical school stuff. Again, excessive fluid, the anti-aldosterone, atrial, natriuretic, meaning you're going to excrete sodium, peptide, gets rid of the sodium, the water follows, blood pressure, blood volume. And again, we discussed this a little bit, okay, and we'll discuss it again. Erythropoietin. The kidneys make this in response to lower red blood cell levels. It's a very important part of control for people who have kidney disease and are becoming anemic, we make Procrit and whatever it's called today, which is this is basically a fairly straightforward polypeptide, and renin, a renin-angiotensin mechanism. I'm not worried about the osteocalcin and the da 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 da. Da. Yeah, and again, it's not something that's as well understood. I don't have an understanding of it. Vitamin D precursor cholecalciferol is we need sunlight to activate it. Okay, calcitrol is the active form of vitamin D that helps absorb it from the calcium, and then we take that vitamin D and activate it further in the skin. So we require activation at this level, at the kidney level, etc., etc. Vitamin D is an important thing. Vitamin D, we underestimate its importance, particularly with vis-a-vis two kinds of cancers, prostate and breast cancer. Understand, I'm not saying take exorbitant amounts. Your vitamin D level should be above normal. You can easily find vitamin D3, which is made from very user-friendly fats that are non-toxic type fats. They're easy to take. They help stimulate. Uh, they they reduce the likelihood of blood clots. You get to my age, a lot of people take that. You do have to stop them if you're having surgery where there could be bleeding. So right now it's sitting on our countertop. We'll fold these. We usually take 3 a day. I should be taking it. Why didn't you remind me? And thymus, we get to. Those are thymus, and we get to that immune system. Can't you wake up? Have fun. See you. Nice chatting to you. What?